Hello everyone, my name is Dr. Sikandar and today we will discuss about the gold guideline for COPD about the management of exacerbation part 4 there. Let's start. So what is the definition of an exacerbation in COPD patient? So they are telling an exacerbation of COPD is defined. So this is defined as an event characterized by dyspnea and or cough and sputum. Means like dyspnea will be there always, and cough and sputum could be with it or not. Like either it could be there or not. That version, like dyspnea will version over like less than 14 days. So exacerbation is a dyspnea and or cough and sputum that worsen less than in less than 14 days. Exacerbation of COPDs are often associated with increased local and systemic inflammation caused by airway infection, pollution, and other insult to the lungs. So they are telling as the symptoms are not specific to COPD, so relevant differential diagnosis should be considered, particularly pneumonia, congestive heart failure, and pulmonary embolism. So we should rule out these things also. So they are telling the goal of treatment of COPD exacerbation are to minimize the negative impact of current exacerbation and prevent the subsequent event also. So short-acting inhaled beta-2 agonist with or without short-acting anticholinergic are recommended as the initial bronchodilator to treat an exacerbation. The maintenance therapy with long-acting bronchodilator should be initiated as soon as possible. In patients with frequent exacerbation and elevated blood eosinophil count, addition of inhaled corticosteroid to double bronchodilator regimen should be considered. So they are telling if elevated blood eosinophil count is there, we know like elevated blood eosinophil count means like more than 300, and there is history of frequent exacerbation, then we should add ICS also. In patient with severe exacerbation, systemic corticosteroids can improve lung function like FEV1 and oxygenation, shorten recovery time, including hospitalization duration, and duration of therapy should normally not more than 5 days. So they are telling in exacerbation, we should give systemic steroid only for less than 5 days. And these systemic steroids are used only in severe exacerbations. And what they do, they used to improve the lung function, means they used to improve the FEV1, they used to improve oxygenation, they used to shorten recovery time, including hospitalization duration and duration of therapy. Sorry, only like including hospital duration. And they are telling therapy should be given for maximum 5 days. Now they are telling antibiotics when indicated can shorten recovery time, obviously, and reduce the risk of early relapse, treatment failure, and hospitalization duration. So what antibiotic did? They used to decrease the recovery time, reduce the risk of early relapse, treatment failure, and hospitalization duration. And their duration should be also be less than 5 days. And we usually give tablet azithromycin 500 milligram OD for 5 days. Then they are telling methyl xanthines are not recommended due to increased side effect profile. So normally we do not give methyl xanthines. Then they are telling non-invasive mechanical ventilation should be the first mode of ventilation used in COPD patient with acute respiratory failure who have no absolute contraindication because it improve gas exchange, reduce work of breathing, need of intubation, decreases hospitalization duration, and improve survival. Now they are telling exacerbation recovery time varies, taking up to 4 to 6 weeks to recover, with some patient failing to return to the pre-exacerbation functional state. So they are telling some patient will never use to return to pre-exacerbation functional state. Following an exacerbation, appropriate measure for exacerbation prevention should be initiated. Now they are telling what are the confounder of or contributor to be considered in patient with presenting with suspected COPD exacerbation. So, like, what could be the differential diagnosis, or what could be like a confounder, like coexisting conditions? So, they are telling like uh, some conditions are like most frequent and some are less frequent. So what are most frequent conditions? So they are telling like first thing is pneumonia. So pneumonia can coexist, maybe co-founder. So they are telling for rule out pneumonia, we should do chest X-ray. Then pulmonary embolism. So they are telling there is like clinical probability assessment, like they are having hemoptysis, surgery, fracture, history of cancer, DVT. Then we should do D-dimer and CT angiography for pulmonary embolism. And they are telling heart failure could be there. So for that we have to do chest radiograph, anti-pro brain natriuretic peptide. So we used to call it pro BNP and BNP and echocardiography. So we should do like 2D echo. Then they are telling like few less frequent conditions should be can be associated with it, like pneumothorax, pleural effusion. For that we should do chest radiograph and thoracic ultrasound. And for like myocardial infarction and cardiac arrhythmias, we should do like ECG and tropi. Then they are telling like currently exacerbations are classified after the event has occurred. So they are telling like okay, so like there is a classification for exacerbations also. So how they used to be classified? So after what event they have occurred. So they are telling if it has been occurred after like uh, treated with short-acting bronchodilators, then we used to tell them like it is mild exacerbation. If they have occurred after treated with short-acting bronchodilator and oral corticosteroid plus antibiotics, then we will call it moderate exacerbation. And they are telling if patients require hospitalization or visit in the emergency room, then we will call it severe. So what is mild? Are treated after short-acting beta agonist. What is moderate? With short-acting beta agonist, they have treated with oral corticosteroids and antibiotics plus minus antibiotics. So like SAVA with oral corticoids plus minus antibiotics. What is severe? So they require hospitalization and visit in the emergency room. Severe exacerbation may also be associated with acute respiratory failure. So they are telling like the current grading of the severity of ECOPD based on the post facto use of healthcare resources is a major limitation of current definition because of global variability in the available resources to treat patient and local custom affecting the criteria for the hospital visit and admission. There is a substantial variability in reported ECOPD outcomes. So yeah, now they are telling about the diagnosis and assessment part. So like first what we have to do, like they are telling complete a thorough complete a thorough clinical assessment for evidence of COPD and potential respiratory and non-respiratory concomitant diseases, including consideration of alternative causes of patient symptom and signs, primarily pneumonia, heart failure, and pulmonary embolism. Then they are telling second we have to assess. So they are telling first thing is like symptoms, severity of dyspnea that can be determined by use of VAS and documentation of the presence of cough. And like what signs like tachypnea, tachycardia we have to check. Then we have to check the sputum volume and color and respiratory distress. We should check like each patient is using accessory muscles or not. Then third thing is like they are telling evaluate severity of using appropriate additional investigations such as pulse oximetry, laboratory assessment, CRP, ABG. So we should do these tests. And finally, they are telling establish the cause of the event. Like either it is due to viral, bacterial, or environmental or other cause. So what are the treatment options? So they are telling like treatment setting. The goal of treatment for COPD exacerbation are to minimize the negative impact of the current exacerbation and prevent the development of subsequent event. So depending on the severity of an exacerbation or the severity of underlying disease, an exacerbation can be managed in either the outpatient or inpatient setting. So more than 80% of exacerbations are managed in OPD basis with pharmacological therapy. So 80% patient we can easily manage with OPD basis. With pharmacotherapy like bronchodilator, corticosteroid, and antibiotics. So they are telling what are the potential indication for hospitalization assessment. So yeah, They are telling if patient is having severe symptoms such as sudden worsening of resting dyspnea, high respiratory rate, decreased oxygen saturation, confusion, drowsiness is there, or there is acute respiratory failure, or there is onset of some new physical sign like cyanosis is there, or peripheral edema is there, or failure of an exacerbation to respond to initial medical management, like patient is not improving on initial medical management, then they are telling like there is presence of serious comorbidities like heart failure, newly occurring arrhythmia is there, or they are telling insufficient home based support is there, then also we have to admit that patient, and we have to treat him in IPD basis. So they are telling now when patient with COPD exacerbation come to emergency department, if hypoxemic, they should be provided with supplemental oxygen and undergo assessment to determine whether the exacerbation is life-threatening and increased work of breathing or impaired gas exchange require consideration of non-invasive ventilation or not. So we have to check requirement of NIV. If so, healthcare providers should consider the admission to an area where proper monitoring and care can be provided. In a less severe case, the patient can be managed in the emergency department or hospital ward unit. In addition to pharmacological therapy, hospital management of exacerbation include respiratory support like oxygen therapy and ventilation we have to give. The management of severe but not life-threatening exacerbation is like given already we have discussed. Now they are telling the clinical presentation of COPD exacerbation. It is usually heterogeneous. Thus, we recommend that in hospitalized patient, the severity of an exacerbation should be based on patient's clinical sign and recommend the following classification. So they are telling like there are three categories. First thing is no respiratory failure. So what is no respiratory failure? So they are telling if respiratory rate is less than 24 breath per minute, heart rate less than 95 beats per minute. There is no use of accessory respiratory muscles, no change in mental status. Hypoxemia improved with supplemental oxygen given by venturi mask means like by till like 24 to 35 if FiO2 is 24 to 35 and oxygen is hypoxemia is improving only on that level of FiO2 and there is no increase in PaO2 means there is no change in mental status and there is no use of accessory respiratory muscles and hypoxemia usually improved at FiO2 level of 24 to 35 and there is no increase in PaCO2 and respiratory rate and heart rate are like less than 24 and 95, then we will call it no respiratory failure in the case of COPD. Then comes a thing like acute respiratory failure, which is non-life threatening. So what is non-life threatening acute respiratory failure? So they are telling if respiratory rate is more than 24. So here comes like more than 24. Previously it was less than 24. So respiratory rate more than 24. Use of accessory respiratory muscle is there but there is no change in mental status. So here it is same like previous definition. So there is no change in mental status, and they are telling hypoxemia is also improving with venturi mask, but it requires FiO2 more than 35. So it requires FiO2 more than 35, but it is improving. But and there is also like they are telling hypercarbia is also there. So they are telling PaCO2 increase compared with baseline or elevated till like 50 to 60, then we will call it acute respiratory failure which is non-life threatening. Then comes acute respiratory failure which is life threatening. So what is life threatening acute respiratory failure? So they are telling if respiratory rate is more than 24 breaths per minute, use of accessory muscle is there is acute change in mental status, very very important, it was not previously there. So there is acute change in mental status is there. Hypoxemia is not improving at all if we are using FiO2 more than 40% also, still there is no improvement in hypoxemia. Hypercarbia is also there. PaCO2 increase compared with baseline, and it is more than 60. Previously, it was like between 50 to 60, but here they are telling in life-threatening acute respiratory failure, it is more than 60, and there is presence of acidosis. So these are three definitions like no respiratory failure, acute respiratory failure, and acute respiratory failure, which is life-threatening. So in life-threatening acute respiratory failure, their PCO2 level will be more than 60. There will be acute change in mental status, and hypoxemia will not improve at all. Now will come what is the management of severe but non-life threatening exacerbation. So they are telling like we have to assess the severity of symptoms. Blood, we should do blood gas and chest radiograph. Then we have to administer supplemental oxygen, ABG, venous blood gas, and pulse oximetry measurement. Then we should give bronchodilator like increased dose or frequency of short-acting bronchodilators, combine short-acting beta agonist and anticholinergics. Consider the use of long-acting bronchodilator when patient become stable. Use spacers or air-driven nebulizer when appropriate. Like if patient is not properly taking like those bronchodilator, then we should add spacers also. Then they are telling we should consider oral corticosteroids, antibiotics if we are suspecting any bacterial infection. They are telling we should consider non-invasive mechanical ventilation, NIV. At all times, we have to monitor the fluid balance, consider subcutaneous heparin or low molecular weight heparin for thromboembolism prophylaxis. So these patients are very prone to thromboembolism. So we should give them subcutaneous heparin or low molecular weight heparin. Then they are telling identify and treat associated condition like heart failure, arrhythmia, or pulmonary embolism. Then they are telling what are the key points for the management of an exacerbation. So yeah, short acting beta agonist with or without short acting anticholinergics are recommended as the initial. So like these are compulsory for the initial bronchodilator to treat the acute exacerbation. So SABA is like recommended as initial bronchodilator. Then they are telling systemic corticosteroids can improve the lung function, means like they can improve the FEV1, oxygenation, and shorten recovery time and hospitalization duration. Duration of therapy should not be more than 5 days. We have already discussed it, and evidence A supports it. Then about antibiotic, they are telling when indicated can shorten the recovery time, reduce the risk of every relapse and treatment failure and hospitalization duration. Duration of therapy should be normally for 5 days. So evidence B supports it. Then they are telling methylxanthines are not recommended due to increased side effect profile. Non-invasive mechanical ventilation should be first mode of ventilation used in COPD patients with acute respiratory failure who have no absolute contraindication because it improves gas exchange, reduce work of breathing and the need of intubation, and decreases hospitalization duration and improve the survival. So we have already discussed these key points in the first slide. Now they are telling what are the indication for respiratory or medical ICU admission. So they are telling if there is severe dyspnea that respond inadequately to the initial emergency therapy. So like dyspnea is not responding. Changes in mental status is there, like confusion, lethargy, or coma is there. If there is persistent or worsening hypoxemia is there, like PaO2 is less than 40 mmHg, and severe or worsening of respiratory acidosis is there despite supplemental oxygen and non-invasive ventilation. And they are telling there is need for invasive mechanical ventilation, means there is invasive mechanical ventilation is required, and hemodynamic instability is there, like there is a need of vasopressor, then we should admit that patient in ICU. What are the indication of non-invasive mechanical ventilation? So they are telling like at least one of the following should be there. So there are 3 points are there. First thing is respiratory acidosis should be there, like PaCO2 should be more than 45 mmHg and arterial pH should be less than 7.35. Means it should be acidic. Second thing they are telling there should be severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breathing or both, such as use of respiratory accessory muscle is there, paradoxical motion of abdomen or retraction of intercostal spaces is there. Third point is like persistent hypoxemia is there despite supplemental oxygen therapy. Then we should give NIV. Like either respiratory acidosis is there or severe dyspnea with clinical signs suggestive of respiratory muscle use is there or persistent hypoxemia despite supplemental oxygen is there. Then they are telling what is the indication for invasive mechanical ventilation. So they are telling if unable to tolerate NIV or NIV failure is there, status post respiratory or cardiac arrest is there, like patient comes after cardiac arrest. They are telling if diminished consciousness, psychomotor agitation inadequately controlled with sedation is there, massive aspiration or persistent vomiting is there, if persistent inability to remove respiratory secretions is there, severe hemodynamic instability is there without response to fluid and vasoactive drugs is there, severe ventricular and supraventricular arrhythmia is there, life threatening hypoxemia in patients who are unable to tolerate NIV is there. Then we should like add we should give invasive mechanical ventilation. So they are telling about the COPD and comorbidities. So what are the key points? So they are telling COPD often coexist with other diseases that may have a significant impact on the disease course. In general, the presence of comorbidities should not alter COPD treatment, and comorbidities should be treated per usual regardless of the presence of COPD. Cardiovascular disease are common and important comorbidities in the COPD patients. Lung cancer is frequently seen in people with COPD and is a major cause of death. They are telling annual low dose CT scan is recommended for lung cancer screening in patients with COPD due to smoking according to recommendation for the general population. So in every patient, low dose CT scan is recommended if he is having COPD. And they are telling annual low dose CT is not recommended for lung cancer screening in patients with COPD, not due to smoking, due to insufficient data or established benefit over harms. Okay, so they are telling if patient is having the history of smoking and they are COPD patients, then we should do annual low dose CT scan. If like COPD occurred uh, because of other cause uh, except smoking, then like we will not recommend the annual low dose CT scan. Then they are telling osteoporosis and depression and anxiety are frequent important comorbidities in COPD patients and are often underdiagnosed and associated with poor health status and prognosis. So these are like very important, like frequent comorbidities. Then GERD is associated with increased risk of exacerbation and poor health status. When COPD is a part of multi-morbidity care plan, attention should be directed to ensure simplicity of the treatment and minimize the polypharmacy. So they are telling we should not give multiple drugs. We should minimize the drugs. We should give selected drugs to the patient. So, COVID-19 and COPD. So, what are the COVID-19 related points in COPD? So, they are telling like people with COPD presenting with new or worsening respiratory symptoms or fever or any other symptom that could be COVID-19 related. Even if these are mild, should be tested for possible infection of SARS-CoV-2. So, they are telling if a COPD patient is having like fever or worsening of like symptoms or like they are having any symptoms which is related to COVID-19, even if these symptoms are mild, we should like do this COVID-19 test. Then they are telling patients should keep taking their oral or inhaled respiratory medication for COPD as directed. Like we should not stop those like oral or inhaled medications in COVID-19. During period of high prevalence of COVID-19 in the community, spirometry should be restricted to the patient requiring urgent or essential test for the diagnosis of COPD. Very important. So we should not perform spirometry in every patient. It is required in like if it is urgent or like essential. in the diagnosis of COPD, or to assess lung function status for the interventional procedure or surgery. Only then we choose to do spirometry. These are not like recommended in every patient with COPD. Then they are telling physical distancing and shielding or sheltering in a place should not lead to social isolation and inactivity. Patients should stay in contact with their friends and families by telecommunication and continue to keep active. They should also ensure that they have enough medication. Patients should be encouraged to use reputable sources for medical information regarding COVID 19 and management. Guidance to remote, like a phone, virtual, online COPD patient follow up, and there should be a printable checklist which should be provided to these patients. So, like they are telling what are the protective strategies in COVID 19. So, they are telling follow basic infection control measures and wear face covering, consider shielding or sheltering in a place, have a COVID 19 vaccination in line with national recommendations. And so, what are the investigations? So, there are only essential about the investigations they are telling only essential spirometry at times of high prevalence of COVID-19 we should do. Pharmacotherapy ensure adequate supply of the medications and continue unchanged, including ICS. So we can give ICS also. So they are telling about the non-pharmacological therapy. So ensure annual influenza vaccination and maintain the physical activity. So like physical activity is also a very important part in non-pharmacological treatment. So yeah, that's it. Uh, Thank you guys for listening.